Thank you very much, Deborah, and also thank you very much for being appointed volunteer to present this to you. Deborah was saying that there would be exciting data. I'm not going to show you any data. I'm merely going to show plans that we have. We're still very much in a setup where we're defining what we want to do in the model. Oops. I have a trouble with this as well. Modeling and simulation group here for the CPTR. So what we want to do in the modeling and simulation part of our work is really come to some tools based on preclinical and clinical data to deliver quantitative PK/PD based models to help sponsors help therapeutic combinations of drugs for TB therapy. Now, part of that is preclinical, and Tawanda will go into great extent into that. I'm going more to look at the, and he's showing real data. I'm going to talk a little bit more about the clinical plans that we have. And for looking at phase 1 type data, we would, or studies, we would look at delivering PBPK type models to help sponsors predict the first in human type of results, and also to try and understand what kind of dispositions we could expect in subjects and intrapulmonary. For phase 2 and 3 data, we would really like to have an understanding of what the disease is going to do, how we look at markers, and how the design of the trial interacts with the behavior of the drug in patients. So I'm really going to look here at the clinical setting. Oops. Now, so there are 3 prongs to this. The last bit, preclinical PK/PD, I leave happily to Tawanda because he knows an awful lot about it. I'm going to talk about the PBPK part, physiologically based pharmacokinetic models, and the clinical trial simulation tools. For the PBPK part, we are now progressing that we've made an application for a grant to develop some models, and I'm going to look at it a bit more in detail with SimSip, which is a CPTR company, to see if they can help us out with looking at disposition of drugs in the lung. Additionally, we also are looking at with the University of Florida to get this done as well. The additional tool is a tool that Pfizer have made available to us as well, where we can study the disposition of drugs in the lung. Then the second part is the clinical trial simulation tools. Here we are making progress, but it's a lot of work, and the more we talk and think about it, the more work it's becoming, as we've also discovered when we were in the breakout sessions just after lunch. Basically what we want to do is we want to develop a drug disease trial model for TB, which is, let's face it, a little bit ambitious. This is a lot of work. We need to have a lot of data, and here is our pledge again for please give us data for good trials that are available that can be analyzed. Where we are standing now is that we've made an inventory of what is available in terms of modeling in the literature, and we've submitted that for publication the other month. And we are now starting to really look at the data that are available, given the data standards that have been developed by the CPTR as well. Then additionally, once we have this data available, we want to develop the model and do this in collaboration with the FDA, and, so that we can get a regulatory buy-in of what we try to achieve. And I'll come to that a bit in a moment. So with regards to PBPK, basically what we try to achieve with PBPK is summarize the complex ADME processes that a drug undergoes. And we would like to account for all the physiological processes that go on in the body and take into account the anatomy of the subjects. This is basically a multi-compartmental approach which we can translate into a whole set of differential equations, so that becomes already quite hairy for a lot of people. That's why we stick it in computers. So the parameters of these models are basically representative of blood flows, of cardiac output, ventilation rates, organ volumes, also the things that Veronique was alluding to in terms of tissue partition coefficients and stuff like that. So schematically this looks a bit like this. On the left-hand side we have the body, so in a virtualized way. So basically we have an arterial blood and a venous blood pool, and the fluxes of drug go through the organs from the arterial side to the venous side. On the basis of that we can then calculate out what the kind of concentrations are that we can expect in the various compartments in the body. Now this stuff is existing. This is all pretty well known. This is being developed by the SimSip consortium. And basically, the aim of this is that on the basis of in vitro data with regards to microsomal activity and tissue partitioning, we can get a good initial understanding of what the likely disposition of the drug is going to be in the body. Now, you can see here that very nicely at the top we see the lungs, because of course they reverse from venous to arterial. But in the patient we need to separate that out, and listen to Veronique, we need to separate it out probably a lot more. But where we take into account the different tissues in the lung that are available, that can be looked at, and where that kind of imaging data that Veronique has presented so eloquently, it can be integrated in this type of model, so that at the end we could have an overall description of the disposition of candidate drugs and candidate combinations into the lungs. The other part of it is a tool that Pfizer has made available as well, which is called PulmoSim, which is a framework for originally inhaled drugs, but we feel that this can be easily or relatively easily be adapted to look at the disposition of systemically administered drugs in the body. So this is a separate but similar kind of thing. Now the other part, which is really the big part of the work that we're looking at, is the development of clinical trial simulation tools. The clinical trial simulation tools that we want to have are basically an integration of the development of the disease, the behavior of the drug, and the behavior of the investigator, i.e. the trial model. And for these kind of things to work well, we need to be able to define various parts of this, and we need to look, for instance, at what the relationship is between biomarkers and outcome. We need to understand what the disease progression is going to be. We need to understand what any placebo effect, if available, is going to be. Then, of course, the pharmacology and the drug disposition needs to be understood. And then on the basis of the trial, we would need to look at what the population is of patients that we look at, what is the likely dropout, what's the likely follow-up of patients, and what is the likely adherence of patients. So this basically translates into, and you can see that we've stolen everything. If you look very sharply, you see that we even put there in the CFU has been overlaid here somewhere. So this is a general drug disease model that we've got. Basically, the drug disease model is for any trial simulation is basically the heart of the tool. So once you've got a model, then you can simulate to your heart's content a range of outcomes out of the trial, which you can then analyze. And the analysis will give you some statistics, and will give you summary statistics, and will give you uncertainty on the summary statistics. That can then lead to you to modify your trial design that you feed then subsequently into your model, and then you can reanalyze this. So in this way you can optimize the trials that you want to do, given the drug that you want to look at, the type of patient that you want to look at, the combination of drugs that you want to look at. So this is a complicated setup, especially because for the TB as a disease, the whole drug disease model is still having to be developed. It's not an off-the-shelf situation that we have here. Also, what is important here is that the marker that I've put in here is CFU. Why did we put in CFU? This is because, of course, historically, and where all the clinical trial data are residing, CFU is one of the parameters that's been looked at. But it could well be that we need to do a translational effort into new markers that become available to understand what would be happening in the future. Now, I'd like to discuss a little bit about the model, because it looked like it was a very small part of the work that that we need to do here. Is one of those four corners is a model. The model development effort is a big effort, and it is going to be a very big effort because we need to identify the type of data that are out there, and we also need to identify what the level of granularity is that we want to model at. You can do, for instance, a top-down approach here, where you look at CFUs here over time when you give a drug, and then you say, I think that this is a straight line. Then you say, this is my model. Now, that is of course one way of looking at it. You could also say, oh, perhaps it is a bi-exponential type of model. There is not necessarily a direct mechanistic understanding here why that would be a straight line or a bi-exponential model. It is just that looks like to be a nice fit. it has the inherent danger that it could be quite misleading because you do lack mechanistic insights this way. So you may want to say, okay, then I'm going to go the mechanistic route. And here we have the other problem that perhaps we are being too expansive here. There's a lot of processes that go on in the various compartments in the lung. If we would compartmentalize it, there's lots of different parts of the mechanism of action that work there, with the immune system working into the bug, as well as the disposition of the drug, trafficking that's going on there. And if we want to develop a model here to describe what an individual patient is doing, we may have to make too many assumptions of what is going on in that individual patient. So perhaps this is also going to be a little bit too difficult. So, basically, what we feel that is going to be the way forward in this is to use a model that I would call a mechanistically inspired model. We take the bits of the mechanistic model that we have, that we understand, and then we try to lump certain parts of this together so that on the basis of that we can identify the pivotal processes that would be going on to understand what the relationship is between disposition of the drug, for instance, in the plasma, to an outcome as in CFUs or TTP over time, and how that would be related to clinical outcome as in cure. Now, we don't have an awful lot of data really in the or modern data that would be readily available. And it may be that we have to steal our inspiration also for instance, the viral kinetics part of things. So here we could see that this is the type of model that Perelson would have, or this is good, have developed for HIV to see how that interacts. We feel that that there you also have, instead of variants, you would have bacteria, you would have target cells. But these kind of models, although this looks quite complicated, these are much more simplified models compared to the models that I showed you a couple of slides ago. So here we are still into the discovery phase of what would be the ideal model that we would need to do this. So where do we stand at this point, beside that we have all these nice plans? What we need to do is we really need to get the right data sets that are out there and that are available to model the dynamics of CFU or any other marker that is available as function of drug exposure, and also to look at the disease progression in a mechanistically inspired setting. This means that we would need to have from patients individual longitudinal data. Ideally, of course, different combination therapies would need to be available so that these can be modeled and tested. Then, to top it all off, ideally also drug-susceptible MDR and XDR strain data would need to be available as well. Once we get all that, then it's the simple matter of making the model that is predictive of these CFUs and link that to the outcome. Then we'd like to test and validate, qualify, evaluate the models that are available with a regulatory buy-in so that we can get a tool that is available, so that we can integrate all this stuff and that we can stick the whole model part under the hood, and we can feed in information such as drug disposition or drug activity, and then come to a trial model that would help us optimize the trials that subsequently can be done. Now, when you start looking at optimizing trials, then also the FDA would like to have a little word in this and try to understand why trials have been designed in a certain way. And if we say like, yeah, because we got a model, then the FDA says, well, show us your model. So in this case, we'd like to have the buy-in from the regulators at an early point in time, where we would really go through the whole exercise of this hand in hand with the FDA, so that the whole review process of the model, the buy-in of the model by the regulators would be greatly made easier greatly, so that at the end of the day we could make submit a full package that would be reviewed, and then what we would say is success is that if the regulators would really decide that the model has been suitably qualified for further work, so that it can be a useful tool for the drug development and decision-making process for clinical trials. So this is where we stand at the moment in time. Before I hand on to Wanda, I'd just like to say thank you very much for your attention.